This afternoon, we have the very distinct pleasure of having as our guest Dr. Henry Moseley, who is a professor emeritus from the Department of Population, Family, and Reproductive Health at Johns Hopkins Bloomberg School of Public Health. Dr. Moseley, I'd like to just extend to you a great thankfulness for being with us today. We're looking forward to your presentation about family planning, a neglected life-saving intervention. Before he gets started, though, I'd like to just share with you all a little biographical information about Dr. Moseley. He's rather well known in the international arena of international health. He served for over 45 years in international population and public health programs. From 1965 to 71, he was the head of epidemiology division at the Pakistan CETO Cholera Research Laboratory in Dhaka, East Pakistan, which of course is now known as Bangladesh, the country of Bangladesh. From there, in 1971, he was appointed to professor and chair of the Department of Population Dynamics at the Johns Hopkins University School of Public Health, where he established the Hopkins Population Center. Then in 1976, he, as director of the Cholera Research Laboratory over the next several years, he led in its transformation to the International Center for Diarrheal Disease Research in Bangladesh. Subsequently, in 1978, he moved to Jakarta, Indonesia, and as a child survival program officer with the Ford Foundation. There he published an analytical framework for the study of child survival in developing countries that laid the foundation for child survival research and has been recognized as a public health classic by the World Health Organization. In 1985 through 1998, he returned as the chair of the Department of Population Dynamics at Johns Hopkins, where he stepped down in 1998. During his tenure there at Johns Hopkins, he co-founded the Bill and Melinda Gates Institute for Population and Reproductive Health. Finally, he also had a curriculum called Star Guide Computer Software, which is designed for the Strategic Leadership Seminars for Health System Transformation. This programming and this strategic leadership training has now been institutionalized in public health training programs in over a dozen universities in China, Indonesia, Nigeria, Ghana, Malawi, and Ethiopia. Finally, Dr. Moseley, he's consulted with numerous national and international organizations, including the World Health Organization, the U.S. Agency of Health, the World Bank, the National Institutes of Health, the United States Senate. He's published over 140 scientific papers. Finally, just a little bit personal information. He was born in China. He was where his parents served as medical missionaries there for the Presbyterian Church. He's been married to Marilyn Moseley since 1956. They have 3 sons and now 5 grandchildren. He also serves as a Sunday school teacher. I don't know how he has time, but he serves as a Sunday school teacher in Baptist Church in Baltimore and is an active member of the Christian Connections for International Health. Dr. Moseley, you have accomplished quite a lot in your lifetime, and we are delighted to have you speak to us today about family planning.
Thank you very much. I am very glad to be here and join the group. And I hope we do not have any more technical problems, since using this tool is a new adventure for me. Let me ask the technician that at the moment the arrows for me to move the slides are not showing on my screen, and so maybe I'll have to ask for the next slide from...
I'll fix that. That's our oversight. We're going to grant that to you right now.
Okay. Very good.
Okay, you should see those arrows now.
That's right. Thank you very much.
Yes, sir.
Okay. In any event, I was asked to make a presentation, and since I've worked in the field of family planning for almost 50 years, I decided this must be the topic that I would like to discuss with the group. And I may be talking to the converted, but perhaps there's some people who have maybe some hesitation about some issues around family planning, and so I think it's useful to discuss these issues. So let me go to the first slide and just give you the definition. And actually, this is a definition that has been developed by Christian Connections for International Health, which is a membership organization with about 140 Christian organizations who work in international health around the world are members of this group. With CCIH has produced a number of publications related to family planning, and the definition they use means enabling couples to determine the number and timing of their pregnancies, including the voluntary use of methods for preventing pregnancy, not including abortion, that are harmonious with their values and religious beliefs. And so we are talking about contraceptive methods or sterilization, but as we note here, we are not defining it in terms of any particular methods, but simply saying that depending on the individual's values and religious beliefs, they should choose whatever method is most appropriate for them. Fortunately, there are many options available, and in fact, many of you may not know this, but that in a recent survey of Americans, 99% of Americans who are American women in the reproductive age group who have ever been sexually active have used a modern method of contraception. And interestingly enough, 98% of Catholics have used a modern method of contraception. Only about 2% of Catholics use natural family planning, and most of them use other methods in spite of the doctrines of the Catholic Church. This is what the practice is in America. And our interest is really in making these methods available to people around the world in developing countries. And so I'm continuing. Don't be shy, I see here, to ask questions. And you can start right now if you want to ask any questions, but I'll proceed. And this is just sort of a summary of where we're going with this session. Answering the question, why Christians should support family planning. And some of these should be pretty obvious. Family planning prevents unintended pregnancies. It prevents induced abortions. It's a life-saving intervention for mothers and for children. It obviously permits parents to better care for their children, which is the reason that they space and limit their childbearing practices. And also, it enhances the freedom of women to live fuller and more meaningful lives and contribute to the health and welfare of the family as well as to society at large. But let's get to more specifics. And this is probably the key message here, that national surveys have been done in over about 140 developing countries. Usually they're done about every 5 years, asking couples about their family planning practices, about their childbearing desires. And out of these data, there's been an estimate made that there are about 220 million married women of reproductive age in the developing world who have what's called an unmet need for contraception. And I give the definition here. An unmet need, we don't really ask them, do you need contraception? But rather they're asked, do you want to not have any more children? And they say yes, they are potentially able to have children. They want to stop childbearing. Or do they want to delay a pregnancy for at least 2 more years? And if they answer yes to that, and then they're asking, are you using any method of contraception to prevent a pregnancy? And they say no. By definition, they are defined as having an unmet need for contraception. This is the assumption that if they don't want to have another child or they would like to delay having a child, technically or theoretically, they should be using contraception. They are not asked directly, do you have a need? And in fact, we know that among people with an unmet need, probably at any point in time, only about maybe 60% might use contraceptives if offered, and they might have other reasons for not using them, including misinformation about how dangerous they are, or thinking that their husband doesn't come home regularly, and for other kinds of reasons. But in any event, this is the best estimate we have in, I think, 2008 when this estimate was arrived at. Now, what does this mean? What are the health consequences for these women with an unmet need for family planning? And I have a little, first I want to sort of ask a question here. And this is one I ask in my class many times when we're talking about fertility and family planning and childbearing. What is the leading preventable cause of maternal death? And the main medical causes I've listed here: hemorrhage, obstructed pregnancy, eclampsia, infection, abortion, and maybe some other causes, congenital diseases and other conditions, maybe heart disease. And people give a wide variety of answers: hemorrhage, obstruction, depending on the setting that they're working in. And but the answer is really shown in the next slide. The leading preventable cause of maternal mortality is unintended pregnancies. Basically, if you ask them what is the main cause of any maternal death, it is pregnancy, because without a pregnancy, a mother will not die of childbirth. But the preventable cause of maternal mortality, the leading preventable cause, are unintended pregnancies. And you ask, what do we mean by this, and what is the evidence? And so I have another slide here. This is based on data in 2008. In that year, there were it's estimated that about 208 million women became pregnant. About 31 million of these pregnancies, or about 15%, will end in miscarriages or stillbirths. That is, recognized miscarriages or stillbirths. But then the rest of these pregnancies will either end in births, and there are at that year about 123 million births. But based on surveys, it's been estimated that about 92 million of these births were actually wanted. There were about 85 million unintended pregnancies, and this produced about 31 million unintended births and 44 million induced abortions. And so that there were almost as many unintended pregnancies as intended pregnancies. I don't know if you have any questions about this, but the point is that about one birth in four, based on women's reporting on surveys, was really unintended at the time the child was born. Either they did not want another child at all, or they preferred to space it for a longer interval. And the problem with unintended pregnancies is that a high percentage of those, actually a majority of those, will be aborted by the women. You might want to know a breakdown of these induced abortions. About 9 million of these occur in China. Of course, China has 1 billion people and we know that abortion is very common in China. About 6 million of these abortions occur in developing countries, actually about 1 million in the United States, and about 29 million, I believe, occur in other developing countries. So that a big problem in the world is the problem of unintended pregnancy. Women who are becoming pregnant, that they did not want another child, or they preferred to delay their childbearing. I don't know if you have any questions about this at this particular juncture, because I do want you to respond if you have any questions.
Yeah, Dr. Mosley, do you have, or maybe, this is Dr. Wood, Tom Wood. The question that I have is, and you may be going to cover it in a while, but of that 85 million unintended pregnancies, how many of those terminated with the death of the mother?
Okay, yeah, I'm coming to that. Thank you very much. Right on the line.
Okay.
Okay. Let me just note the fact that, to go back to the abortions, about 49% of all abortions that occur are unsafe. That is, they're done by totally unqualified persons or by the woman themselves. And that's 49% of all abortions, about 22 million abortions. Actually, in Sub-Saharan Africa, where abortion is largely illegal, 97% of abortions are unsafe. And of course, women use all kinds of things, including taking insecticide or using feathers or sticks or other kinds of things to try to terminate the pregnancy. And there was a period from about the early 1970s to about 1995 that the abortion rate was going down, but it hasn't changed very much in the last decade, and probably is increasing because there are more women entering reproductive age because of the growth of population. Okay, let's look at how many women are dying. Of the 22 million unsafe abortions to avoid an unwanted birth, we have about 47,000 maternal deaths each year. That represents 14% of all maternal deaths. And almost all of these, let's say, are due to unsafe abortion. The risk of dying from abortion varies by region, as I note. In developing countries like the United States or Europe, the risk of dying of abortion is about 1 per 100,000. Some deaths do occur, but it's extremely rare, particularly with very early abortion, which might be done by suction aspiration. In developing countries, it's about 330 per 100,000, 300 times, but even more than that, depending on the setting that it is done. But the fact is that 99.9% of abortion-related deaths are occurring in developing countries, particularly where there are unsafe abortions. Okay, now that's the abortion-related deaths. Obviously, those are the deaths. There are probably at least 10 times more complications as a result, women not dying of abortion, but having complications with infections and other complications that require hospitalization and may require hysterectomy or will produce permanent infertility. So that this, in effect, is a minimum estimate of the damage done by abortions, induced abortions, particularly the illegal abortions. But you asked about maternal mortality, and this is the estimated number of deaths, how many women are dying of unintended pregnancies. And I just show the calculation here. There are 85 million unintended pregnancies, there are 44 million abortions, 47,000 abortion deaths. Among the unintended births, 33 million. If we assume the death rate from unintended births is the same as from intended births or intended pregnancies, then we can estimate that there were 110,000 maternal deaths due to unintended births. And therefore, the total maternal deaths from unintended pregnancies are 157,000. In that year, there were an estimated 342,000 maternal deaths, and so we can see that unintended pregnancies accounted for 46% of all of the maternal deaths occurring that year. Perhaps yes.
I'm sorry. I was just going to let you know that there's two questions.
Good.
This is an appropriate time. Natalie Sanders from the Public Health Christian Fellowship there at Johns Hopkins, she asked, how do you respond when Christians say you are not trusting the Lord or God when using family planning?
Well, My response is that, this is an individual decision. I'm not going to argue with their decision about their relationship to God. I also know that, there are religious groups who would say that they are not trusting God if they take a blood transfusion.
Right.
I will have, and as a personal decision, I respect that. And, that is their own personal decision. My point is that I would not impose that decision on someone else, because we know, for example, even among American Catholics, 98% have used a modern method of contraception, in spite of the fact that the Church has a very strict, religious doctrine against the use of modern method of contraception. It does not have of course, the Church does not oppose the use of family planning. I think you should know that the natural methods of family planning, the standard days and other methods are perfectly acceptable. And so actually, I don't know of the teaching of any church that is against the use of family planning. And the Catholic's teaching is not against the use of family planning, but against the use of modern methods, what we consider as modern methods of family planning.
Yes, sir.
I respect it if they can make that decision. And I presume they're talking about they would not even use natural family planning either, because family, or maybe perhaps they're concerned about the use of modern methods. Okay, and then there's another one. Of the number of unintended pregnancies, how many are due to contraceptive failure? It depends on the contraceptive method, because the failure rates vary considerably. If you take, for example, if you take the pill exactly at the same time every day, the failure rate is less than 1 in 1,000. But the way that most people take the pills in the United States, the failure rate is about 6 per 100. 6 per 100 pregnancies. So about 6% of women will have a pregnancy in a year using the pill the way they ordinarily do it, where they sort of skip it or forget about it, or they don't feel well or something like that. And condoms, again, also are about 98% effective, but the way most couples use them, they probably are closer to 85 to 90% effective. So it depends on the use of the method, but indeed, in a country with very high contraceptive prevalence, a high percentage of the abortions are due to contraceptive failure. I mean, you can think of this conceptually. If 100% of women were using contraception, then all of the unintended pregnancies would be due to failure. And whether or not they're aborted depends on the decision of the women. If 0 are using contraception, none of the pregnancies would be due to contraceptive failure. And so you can see that the higher the proportion of the population using contraception, the more likely an unintended pregnancy is going to be due to failure. On a global scale, I would say, though, it's probably only about 20% are due to failure. I don't have that number, but that would be a guess, because on a global scale, we don't have that high level of use of contraception. Okay. Maybe I'll move on. This particular estimate, it just assumes that we somehow could have some kind of a perfect intervention, and every single woman, these 222 million women who have an unmet need, would avoid a pregnancy, an unintended pregnancy. That's not very realistic, but there have been another estimate. That's not even just the unmet need. That is all women, whether they had an unmet need or not, would avoid an unintended pregnancy. In other words, if we could avoid all 85 million unintended pregnancies, what might we expect? And that's a theoretical number. But among the 222 million who do have an unmet need, and this graph shows you in different populations in developing countries, the percent of women who report that they wanted to stop childbearing or space and were using contraception. In Sub-Saharan Africa, that's 27% of women who have an unmet need. In Central Asia, that's places like Armenia and Georgia and other places, it's about 10%. South and Southeast Asia, which is predominantly India and Bangladesh, Pakistan, it's 16%. And in Latin America and Caribbean, it's about 15 to 16%. So there are very substantial percentages in all regions of the developing world. Now we ask the question, let's say an achievable goal would be to not prevent all possible unintended pregnancies, but among the women who have an unmet need, this would be, you might say, a quote target, not in the true sense, but a potential population where unintended pregnancies could be prevented. And so if we were able to reach these women alone, we would avert about 54 million unintended pregnancies, not all 85 million. But this would result in 26 million fewer abortions, and it's estimated that this would prevent 104,000 maternal deaths. So if the women who had an unmet need had services available and would use them, we could reduce maternal mortality by 30%. And the point here is that this reduction is being achieved not by improving maternity services, but by simply helping women avoid a pregnancy that they did not want to have. I should say that, again, when we talk about 104,000 maternal deaths, we know that maternal morbidities are at least 10 times greater than that, and so we're talking about more than 1 million maternal morbidities, including things like vesicovaginal fistulas and permanent infertility and all the other complications that can occur with childbirth short of death. Okay, let me go on. What is the empirical evidence that contraception prevents abortion? Because those numbers were derived from interviews and some models and so on. But this is a study that was done by Charlie Westoff. There are almost 60 countries where abortion is legal. And therefore, we know what the abortion rate is in the population. We also know what how many women are using contraception. And what he did was just do a basic cross-tabulation in this graph of the percentage of women using contraception, which goes from 0 to 80, and the abortion rate, that is the number of lifetime abortions a woman would have. And we see that almost a linear relationship, that as more and more women use contraception and obviously avoid unintended pregnancies, the abortion rate drops very close to 0. Whereas in countries where contraception is not available or not used, including some countries where abortion is almost a method of family planning, like in Ukraine and Japan, the women will have 2 or 3 or almost 4 abortions over their reproductive life. So that this is, clear evidence that as contraception is more readily available, the induced abortions will decline. I hope this will be intuitively obvious, but in any event, this is the data. I want to add one more point here about abortion, and that is that in a international study, they looked at the abortion rates among women.
You may have lost Dr. Mosley there momentarily, so we're going to hold out for just a moment. Dr. Mosley?
Yes.
Oh, okay.
Okay, I'm here.
Yes, sir. I'm not sure what happened, but I'm glad to have you back.
Okay. Well, how long was I gone? Hope not too long.
Just for about 5 seconds. Yes, sir.
Yeah. Okay. In any event, the data shows for countries, in the analysis of countries where abortion is legal and illegal and where they have estimates of the abortion rates, the abortion rate is approximately 30% lower where it is legal than where it is illegal. This seems to be counterintuitive, but the fact is that often in countries where abortion is illegal, which is essentially all Sub-Saharan Africa countries among others, that contraception is also not readily accessible. And so women are forced to resort to illegal abortions. And therefore you have relatively high rates of abortion, whereas typically in countries where abortion is legal, contraceptives are also widely available. As you see in this chart, that the majority of the countries with high contraceptive prevalence have low abortion rates, the abortion rates are lower. The point is that the rate of abortion in a country is really not dependent on whether it is legal or illegal. It's dependent on the availability of contraceptives. And I think this is a crucial message for Christians who really want to reduce abortion, that making it illegal doesn't reduce it, but making contraceptives readily available to women who want to practice contraception, and making all methods available according to their religious beliefs will reduce abortion to very low rates in any population. And this is one message I definitely want to get across, because all of us are concerned about the abortions as a Christian. I think that's pretty universal among Christians. Christians may vary on family planning, but I don't think any of them vary on abortions.
Dr.
Any
Mosley?
questions about that?
Yeah, I wanted to ask one, Dr. Mosley. I think, and I'm glad that we're addressing this issue today. I think sometimes as Christians we avoid this topic, but we certainly should not. I think it has enormous implications, as you have well described. My question is, this dilemma, I think, for Christians is, I totally concur with what you're saying, but I think sometimes as Christians we're a little bit hesitant to promote the use of contraceptives for fear that it will be perceived that we are promoting the use of contraceptives in unwed couples, and that will be that will be misunderstood, and because we want to promote abstinence, yet we want to make contraceptives available to married couples. Anyway, I know you've been asked this question many times, but can you just elaborate a little bit about that sort of the little dilemma there?
Well, I think in the United States this is to be a real serious problem, because all of our media, as you know, and in fact in what's going on in our society, is that unmarried people are having sex all the time. And the media, shows it on primetime television and all that. And what happens if we don't make available contraception to them, we're just guaranteeing that they're going to have an unintended pregnancy, and these people in particular are going to have an abortion. And so, what we're saying is we prefer to have abortions available, legal or illegal, rather than preventing a pregnancy. I mean, that is simply the choice you're making by saying that unmarried people would not have contraceptives available. I mean, I agree that I think, sexual relations should be within the marital union, but in our culture, to start with, but in cultures all over the world, young people and middle-aged people, as far as that goes, are having sexual relations, and they should be protected not only from pregnancy but also from sexually transmitted diseases, including HIV, which, as you know, is a horrendous problem.
Yes, sir. Yes, sir.
So that to me, as a Christian and as a public health professional, and who wants to prevent abortion, I feel that contraception needs to be available, and we need to encourage young people to avoid sexual relations. But actually, there's no data to show that making contraceptives available encourages young people to have sex. In fact, cross-national studies, for example, one study was done comparing the United States with the Netherlands and Denmark for adolescent pregnancy. And these two countries start sex education basically in grammar school and carry it all the way through school, and young people have access to contraceptives at any age, virtually. And basically what they showed was that the amount of sex in Denmark, Netherlands, and the United States was the same among adolescents. But the pregnancy rate in the United States was 10 times higher.
Right.
And so all we didn't reduce the amount of sex, but we just guaranteed that American kids would get pregnant, and of course they're going to have abortions, 10 times more abortions too. So this is a choice we make as Christians, and as a public health professional, I'll be very frank that I've made the choice that, shall we say, contraception is the lesser of two evils. And anyway. Any other, and then other people may have other positions on that, but this is where I have to come out working in the field and working all over the world in about.
I definitely understand how you came to that decision, and it's still it is a. And I know you're more aware of this than I am, as you are an expert in this subject matter. It still, in Christian circles, is controversial, but I certainly, absolutely respect how you came to that decision. It's convincing evidence.
Yeah. I'm really sad that it's controversial, and I feel like having talked to many different Christian groups, once they know what the evidence is. Many of them will recognize that they were, acting on beliefs, but not on, what the real situation was. And once they learned about the reality of the situation, many of them said, I think this is what we should do as Christians. Which is to let people, give people the information that they need, and and work on. Teaching them to make the right choices in life, but not denying information to them. Anyway, let's move on. That's a great question, though. I just want to say, empirical evidence that contraception prevents maternal mortality. This was actually work that I did in Matlab, Bangladesh, and this is an population area that we worked in, and really designed a family planning program that was adopted nationally. And this shows the trends in birth rates. From 1966, when I first went there, the birth rates were about 6 to 7 births per woman in her reproductive life. That meant, of course, some women were having 12 or 13, and some were having 4 or 5. But in any event, we initiated a family planning program around 1976 in part of the population as a study to see how we could work it. And you see the decline in birth rates both in the population where the family planning program was initiated as a study, and then later nationally in what's called the government area, so that ultimately now in Bangladesh the total fertility rate actually today in 2012 is about 2.3 children per woman. It's almost a 2-child family. But the point is that you see the rapid decline in birth rates in fertility And I had some lines here. I see they moved a little bit here, but basically they go from about 1983, when the fertility rate was about 5 births, to about the year, should be to the year about 2003, when we're down to the 3 births. The birth rate has fallen 40%. And the next slide just shows that in that time period from 1983 to 2003, the number of maternal deaths, which is in the red, fell from about 30 deaths in the population down to less than 20. Now you'd say that's a 30% reduction in maternal, more than a 30% reduction in maternal mortality. But what we did in the analysis was to show that if there were no family planning program, the number of births would have increased, and if you kept the death rate the same, we would have expected by the year 2003, 20 years later, 40 deaths instead of the observed about 18 or so. And that a lot of these deaths were prevented simply because the women did not have pregnancies, and obviously these would be unintended pregnancies. And then we show in the blue the fact that in addition to not having a birth at all, women delayed births. They didn't have births when they were too young. They didn't space them with too short intervals, and also they didn't continue to have births into old age. And so that change in pattern of births also caused a reduction in maternal mortality. And so it just shows, again, what should be intuitively obvious, that if women can control their fertility and reduce the number, avoid having a baby when they're too young or too old, that we would expect the maternal death rate to decline. And it really declined primarily due to the fact that women were having fewer babies in this population over this time period. Let me move on to, let me just say that there was a recent study published in Lancet that just showed a model based on real data that just showed the contraceptive prevalence in the model is shown on the horizontal scale, and the percent reduction in maternal deaths is shown on the vertical scale. And the model just simply shows that as contraceptive prevalence goes up in a population, we can expect up to a 60% reduction in maternal mortality based on preventing unintended pregnancies and preventing abortions as a part of that. And again, that was, but I won't dwell on this particular graph. Now, how about child health? Not surprisingly, I'm not going to talk just about mothers, but about children. And again, questioning what is a leading cause of neonatal, infant, and child morbidity and mortality. I'm not saying the leading cause, as I said with maternal mortality, but a leading cause. And again, there's a lot of data showing that it's births among women who are too immature for healthy childbearing. And for any of you who are delivering babies, you know that if the woman is 12, 13, 14, 15 or something, it's not only dangerous for her, but also for the newborn. Prematurity, for example, is and low birth weight is a serious problem there. But also births that are not sufficiently spaced to give the mother time to recover, and I'll go into that more. And also births that are unintended and therefore not given adequate child care, and there's a lot of data about that. I won't go into that right now, except to say that, for example, in Haiti, before they had the earthquake, there were some studies, and there were an estimated 50,000 homeless children, basically from unintended births, that were just left to wander on the streets. This, when we think about homelessness among children in slums and cities around the world, we have to recognize that this is one consequence of unintended births, where they're not given adequate child care. In fact, they're not given any care at all, but they're just abandoned. But let me move on. First, this is a graph that makes a generalization. I'll go into more detail in a minute. But basically, this simply shows for about 40 countries that the higher fertility a country has, from about 2-child family to about the 7 or 8-child family, that the higher the child mortality rate. This is the under 5 child mortality death rate. And the relationship is really rather striking, that high birth rates are associated with high death rates. And part of that, you might say, is due to poverty, but part of that is just due to the pattern of childbearing, and for several reasons. And this graph just makes the point that in order for a population to have 7 or 8 births on average per woman, meaning some have 10 or 12 or 14, and some maybe have 4 or 5, they have to start childbearing very early, which means they marry very early. And I just show, this is particularly for African countries, the median age of marriage is, for Chad, for example, about 16 years old. Ethiopia, 16 in Nigeria. And then the median age, meaning that half of the women are married before that age. So in Chad, for example, half the women are married before the age of 15. Or even in a lot of countries, you see the median age of marriage is below 18 for the majority of these countries. That means half of the women are married before that age, meaning they're married at the age of 12 or 13 or 14. Typically, they may be married when they have the onset of menses. Combined with that, because they're married very early, and the husband and the parents want them to have lots of babies, they begin childbearing very early. And you see the percentage of women at ages 15 to 19 beginning childbearing, and if you start down at the bottom with Chad, which had the very early median age of marriage, 37% have begun childbearing before, in the age group 15 to 19. Actually, a lot of those began before age 15, but at least 1/3, and many of them had already 1 or 2 children by the time they're age 20. So the point is that in populations with high fertility, these populations have very young age of marriage and very young age of initiating childbearing, and this alone will cause both maternal and infant, particularly neonatal, newborn mortality. The other thing that is really important to note is the fact that in order to have a lot of births, because the childbearing years only are, say, typically from 15 to 40 or something, about 25 years, you've got to have births at very short intervals. And pregnancy takes 9 months, and so then the woman may not have much time to recover. And this is just showing for, again, a lot of countries, a majority in Africa, but you have other countries like Bangladesh, Indonesia, Peru, and so on, that upwards of about 25% of births occur at intervals of less than 2 years, and upwards of 70%, 50 to 70% of births occur at intervals of less than 3 years. Now, you might think that, well, gee, I have 2 kids and they're only 2 years apart, so what's so bad about that? But the point is, if you're having 8 or 10 kids and they're less than 2 years apart, you can imagine the tremendous burden, physiologic burden this puts on the mother and on the pregnancy itself, resulting in very poor birth outcomes. And so in the, here in America, we don't think of a birth being less than 2 years apart as meaning very much because we stop at 2. But if if you're going to have 10 or 12 births and you have them at every 2 years, then it really has a tremendous impact on the mother. And we have empirical evidence of this. This is just first one graph, and I want to show you more data. But these are just showing the percent increase in death rate of children under the age of 5, depending on whether the birth interval is less than 18 months or more than 18 months, 18 to 24 months, versus more than 24 months. And for example, in Egypt, if the birth interval is less than 18 months, the child mortality, the risk of child dying is 200% higher. If it's under 2 years, it's still about 60% higher. And so that we see in country after country, and this is just 4 countries here, that a short birth interval is associated with higher mortality of the newborn up to the first several years of life. And I want to show this in a more extensive study. This is a study, and I just want to indicate that in this study, they looked at the effect of birth intervals on child malnutrition as well as child mortality. And I'll just run through these graphs very quickly. Here in the horizontal scale here, we have the interval, actually they took it from the preceding birth interval. And I have a circle around the relative risk of death of 1, which is basically a birth interval of 3 years. And what this graph is showing for 17 countries is that shorter birth intervals, if you move to the left, the relative risk of death goes higher, reaching almost 3 times higher risk of death if the birth interval is less than 18 months. And again, I want to stress that short birth intervals are the birth intervals that are seen with high fertility populations. And just shows this is neonatal mortality, the death rate in the first month of life. But even if we look at the infant mortality, the death rate in the first year of life, again, as birth intervals are less than 3 years, the death rate goes up 2 to 3 times higher. This is under 5 mortality. We see exactly the same pattern. And even child malnutrition, that with short birth intervals, the odds that the children will either be stunted or malnourished is much higher with short birth intervals. So high fertility itself has an adverse effect, and I hope it would be intuitively obvious again that if you're going to have 10 or 12 kids and you're having one every 18 months to 2 years, you are going to be tremendously depleted as a mother. You're more likely to die. Your child is more likely to be premature or low birth weight, or even spontaneously aborted because you're not able to carry that pregnancy to term. Now, this again is a model based on the data I've just shown you, and it sort of said, well, if all the birth intervals were at least 24 months or at least 36 months, how many lives would be saved or how many children would die? And this again is based on data at around the year 2008, and the blue bar shows that under the existing conditions, there were about 8 million child deaths, deaths of children under 5 in that year. If all of these births had at least a birth interval of 24 months, you would have prevented almost 2 million deaths and therefore dropped it down to a little over 6 million. If they could have had births at 3-year intervals, it would reduce the death rate by another 1 million, and therefore altogether, in effect, saving about 3 million lives. And so, again, short birth intervals, the women being unable to space their pregnancies results in a higher risk of death for mothers, as I mentioned earlier, and for their children. And these numbers are very large. We're talking about millions of children in the developing world. I just want to reiterate again with the next couple of slides. In Sub-Saharan Africa, the unmet need for contraception exceeds the current use of contraception. And here I have about 7 Sub-Saharan African countries, Cameroon on one end and Zambia on the other end. We see the current use of contraception is only 10 to 20%, but the unmet need, which is in the orange bars, ranges more than double or even 3 times higher than the use of contraception. So in these countries, women are wanting to terminate childbearing or to space their births, and they are not using contraception. And typically because they don't have access to it, they don't have the knowledge about it, or they have misleading information about contraceptive methods. This again just shows for 6 African countries what if we could meet the unmet need for contraception and prevent unintended pregnancies. It indicates the number of child deaths that could be prevented in these populations. And this is just within individual countries from 200,000 to 1 million child deaths over a 10-year period. But a substantial number of child deaths just by helping women space their pregnancies or avoid an unintended pregnancy. So that's for child deaths, not maternal deaths. I want to have just a couple more slides to finish this. This just is asking the question or answering the question, well, how much is it going to cost to do this? And the number here is 100 million in family planning. It says we could get 3.6 million contraceptive users. That sounds like a lot of money, but what we're talking about is $30 per contraceptive user per year, or 8 cents a day. And if we could provide the services to women in the countries that I showed you earlier, we could prevent 3.6 million, we get 3.6 million users, prevent 2.1 million unintended pregnancies, therefore preventing 825,000 abortions, induced abortions, and all of these would be illegal in these African countries, preventing 70,000 infant deaths and 4,000 maternal lives. So this is really a very cheap intervention compared to the cost of trying to save mothers' lives by improving maternity services. Not that that should be done, but we are providing maternity services to a huge number of women who basically did not want to have that pregnancy to begin with and would not have to go through all the dangers of childbearing. This final slide just says that they are cost effective, and again, this would be presented to a donor community. This is in Zambia. It's showing that a family planning program for that whole country might cost $27 million, but it could save a huge amount of money if the women could prevent the unintended pregnancies in terms of therefore having to provide for these children education, immunizations, water, maternal health care, including deliveries and malaria prevention and so on. It could save about 3 times more, almost 4 times more than the investment. And so that if you have limited money for health, family planning should certainly be one of the first things that are done to help families really care for their own children and for themselves, and to protect the life of the mother and the children that are already there. So let me conclude, and then we can have some discussions here. What do Christians need to do to be more effective in saving lives? I think we need to change our organizational cultures. And as I say, change our mental models. You mentioned some of those. If we make family planning available, then maybe women will have more sex, unmarried people will have more sex. And as I say, there's lots of data on this that shows this is not true. So that's not a reason to withhold contraceptive services. The other thing is, I've given this talk where to the core group where they're primarily concerned about child health and maternal health, but they're only talking about delivering curative services and safe motherhood delivery and immunizations and so on. And I say, when you're doing that, you're looking at mothers primarily as instruments for bearing children, not as women who want to take control of their own lives. And so all you care about is let them have all the babies that, that nature permits, and we're going to do whatever we can to save the lives of the mothers and the babies. And I think we should recognize that these women want to make choices in their own lives, and they should not be considered primarily as instruments for bearing children and raising children. So finally, family planning not only saves lives directly, but it also promotes family welfare. It slows population growth. this larger area that we may not be concerned about, but just think about the family itself. Irrespective of population growth, the family itself is better able to care for itself. The women are able to have time to complete their education before they start childbearing. They can determine the timing and spacing of their births, the number of births, and then be able to make more effective contributions to their family, and the families can invest more in their children. And to me, all of this is things that Christians should be totally supportive of. When they see the information and see the data. Anyway, I will conclude here and just see if there are any questions or discussions, because I've covered quite a bit.
Dr. Mosley, I appreciate that. Was a fantastic presentation. I thought I might ask, would you mind, I would love it if you had like some hallmark studies, landmark studies, and I'm sure you do, that support your premise that making available contraceptives does not, promote more promiscuous, behavior or intercourse outside of marriage.
Absolutely.
Yeah, if you could send that to me, and I can make that available to other participants in the health forum. Thank you.
I will definitely send that data to you. There are both old studies and some more recent studies, including school-based programs that have been carried out in the United States that show that, to me, I am as seriously concerned as any Christian and non-Christians as well about the promiscuity. But as we should know, the driving force for this is really our entire culture, the media, the television, the music that the kids have, the movies that they see, the stuff that they see over the internet, and
yes,
that letting them know the physiology of reproduction and how to avoid a pregnancy is not going to be the driving force.
Right.
And that's the reason that there's been no data to show that this actually causes this. So it's a myth that's been circulating through the Christian circles for ages.
Yes, sir. Anybody have questions for Dr. Mosley? We're a little bit past time here, but we have time for a couple. Mary Lou?
I have a question. Thank you so much for a good presentation, Dr. Mosley. My question is this: what is the best way for Christians to approach this subject in countries in Africa, for example, so that it does not look like the Western person is coming over there to maybe limit their family size? It would seem like it would be important to engage the husbands also, as well as the wives. And do you have any ideas on how to approach this so they won't think we're just trying to have them have fewer children?
Well, the thing is that pardon me, I'm getting an echo here. The thing is that, as I said, the African women and men want to space their births and to limit their childbearing. So we're not going there to tell them to do something that they don't want to do. I've worked with quite a number of mission organizations in Africa. I lived 3 years in Kenya, and I've worked in Nigeria and Ghana and quite a number of other African countries. And the fact is that the Christian missions, all of them that I know, that I've worked with, have promoted family planning. And as some of you may know, there are Christian health associations in Africa. And they have come out, which is really the associations, they're in multiple countries, Christian health associations, which are the Christian organizations delivering health services. And all of them have come out very strongly in supportive of providing family planning to women who want to space and complete their childbearing. So this is not a Western idea. Actually, you should know Africans have been spacing their births since well before we ever thought about it with postpartum abstinence. This goes back thousands of years. The women would stay away from their husband for up to 2 years to space their pregnancies. And so this has been a long-standing African tradition. We didn't invent it in the West.
All right. Well, thank you, Dr. Mosley. I'm always trying to be very vigilant with the time. I'd love to talk a lot more about this. If you all have ongoing questions for Dr. Mosley, please send them to me, and I will forward them to him because we are past time. Dr. Mosley, thank you so much for, again, an excellent presentation.